Okay, so we see you. Can you present the case?
Yes, of course. My name is Hristo Anghiuf, and I'm going to present you today's case. It's a case of 77 years of age female with heart failure, third grade by NIHA. 2020 AVR was performed with trifecta valve size 21 and repair of mitral valve with annual flex 28 due to severe aortic stenosis and severe mitral regurgitation. Due to full AV block after the surgery, a permanent pacemaker was implanted. The patient has arterial hypertension, diabetes with insulin treatment, and chronic kidney disease. For the status, she's 178 centimeters, 75 kilograms, body surface area 1.9, body mass index 24.7 kilograms per square meter. According to the laboratory test, you can appreciate mild anemic syndrome with increased levels of creatinine, increased levels of glucose levels. The creatinine is with calculated glomerular filtration rate by the MDRD equation is 19.3 milliliters per minute, which puts her in 3B KDIGO stage. According to the echo, the patient has severe left ventricle hypertrophy with preserved ejection fraction. Mitral valve after the plastic is with mild intra-ring regurgitation. Aortic valve trifecta is 21 size with peak gradient 42, mean gradient 20 with severe intra-ring regurgitation. Tricuspid valve is with moderate to severe regurgitation. This is the echo before the procedure. You can appreciate the severe aortic regurgitation and transthoracic echocardiography in the first video. In the second one is transesophageal echocardiography, where you can appreciate the mild mitral regurgitation. Aortic valve is from the TE with severe aortic regurgitation, again intra-ring intervalvular aortic regurgitation. We can see that the non-coronary leaflet looks like there is a tear in the leaflet. There's again the regurgitation. We know that trifecta valve has some problems during the years, and in July this year, Abbott stopped making the trifecta surgical valve. Some of the studies showed that the trifecta valve failure was caused by cusp tears or leaflet calcification, and we believe that this is the reason for the severe aortic regurgitation at such early stage after the surgery, and the chronic kidney failure is one of the risk factors for this early failure of the valve. We discussed the patient on heart team. You can appreciate how high are the risk scores. Euroscore 2 is 13, STS score is 8.4. We decided to schedule the patient for TAVI. These are the available devices that we can use to treat the severe aortic regurgitation. We performed CT to assess properly the patient. You can appreciate that the left coronary artery is a bit low, 6.3 millimeters, but according to the reconstruction, there is fair enough space, about 6 millimeters, from the ring of the valves from the ring of the valve to the ostium of the left main. Femoral arteries look fine. We do not expect that there will be any problem for the procedure. So we decided to perform TAVI valve in valve. The main problems here are the possible coronary obstruction, because the low levels of the left coronary artery patient prosthesis mismatch is something that could be a problem, or migration of the prosthesis, because this trifecta valve is a bit slippery for transcatheter valve-in-valve implantation. The patient prosthesis mismatch can have really devastating result in the patients, because 90% of the patients with severe patient prosthesis mismatch have increased mortality risk. 44 of them in the intermediate patient prosthesis mismatch has severe heart failure. We calculated the index of effective orificial area in this particular patient is 0.87, which puts her into the mild patient prosthesis mismatch. We decided to use a Allegro valve because it's self-expandable, the self-expandable structure of the stent with convex and concave areas for optimization of the effective area of the valve, which is really helpful in the patient with small aortic area. The radial force of the stent is created to be really strong in the location for the anchoring, with reduced radial force in the outflow section, which allows it to follow the natural movement of the ascending aorta, and this can have additional positive effect on the long-term results in the patients. Also, the supraannular positioning of the valve is with higher benefits in vitro, with better hemodynamic characteristics compared to the other devices. Transcatheter system can be used even in patients with low annular diameter.
I'm sorry. I'm sorry to interrupt, Dr. Angelov, but can we see the case? And while we're looking at the case, you can go on, because the time is not very long for each case. So maybe we can continue to the case. Otherwise, the explanation why you chose Allegro is a very interesting one, and it's really the valve that is dedicated to small orifices and to...
Иди на другата проекция. Не на тая. Okay, so we pass with the valve system into the left ventricle. You probably saw we released the valve from the introducer sheet. So the next step is to achieve a good positioning of the valve. So in this case, we have already surgical valve prosthesis. So our marker would be the ring of the biological prosthesis. This is trifecta valve, as Dr. Angel said. So the Rengenov positive marker of the valve should be on the level of the ring of the surgical valve. So let's check. We are too deep in this projection. So
let's check in other.
Дръж водача малко.
I think that looks
good. So, the test.
Okay.
That looks very good.
This is Kaplan review, so we have to be on a little bit more back. So let's check.
I think we are. Yeah, I will push.
Дай сега, дръж, ако обичаш.
То как сега? Държа.
Влизам малко.
Okay.
Така, натисни водача. Айде сега, леко назад, излизам. Излизам.
So they're using the guide wire to help the
Yes.
the position of the valve.
Okay,
Yes.
check, please.
I think that looks
Push.
good. A
No,
little
it's
We are
more.
too
too deep.
deep.
A little more. Yes.
Push the wire, please.
Yeah, I'm pushing.
Check,
Okay.
check.
Good. Looks good.
Let's check in the other projection.
Okay.
We're going to cast parallel up view. So, check.
This projection is too deep.
In this projection, the valve looks like deeper. So the risk of this patient is predominant aortic regurg. This is the first. And the second reason is the low left coronary ostia. So we have to be very precise about the depth of the valve. A little bit back. Check.
Danger.
Test. Maybe it's okay.
It looks okay.
It's,
We must
So-
space if you.
Let's go to pace. The specific characteristic of this valve is the three steps of the releasing of the valve. The first one is the, sorry,
Check. Check. What do you think about the dip? Too deep. Yeah, oh, now.
check. It's okay. Open.
I'm opening.
Yes. Stop the pace. Okay, colleagues, sorry. You saw that the first part of the valve is opened very fast. So we have to check the position and the coronary. Sorry, just
Before
a
the
minute.
final.
Guru, please. It's coming. Okay. That's okay.
The nose should be go upper of the valve. That is doing Dr. Simeonov.
We must to
Be very
pull
gently.
out to liver inside the valve,
valve.
but for some reason it's not happened. Okay,
Okay.
super. That's it. That's it.
Okay. So let's check the position. I'm ready. Angel? It's okay. We
Good.
can't let
Looks
coronary.
perfect. Looks perfect.
So let's go to open the
You
valve.
can-
The first projection with this.
This one. Okay. If you want, we
We have to align
yes. and
dot markers
Okay.
in the one line.
And again, we will pace on rapid pacing because
So in this case, because of the predominant aortic regurgitation, and there is no stenosis of the valve.
there is no calcium.
Calcium, yes. Thank you for the correction. We'll again pacing about 140 maybe to open the valve finally. So they pace. Let's start. Cheers.
Yeah, I'm trying.
Right, done.
Wait.
Left. Left. What's left?
Okay.
Okay, so push the wire, push the wire. I'm going out, push the wire.
Okay.
Okay, okay.
Super. Super. Okay.
Very
Release the,
good. Wonderful.
I'll
Bro.
Да. Нека да извадят пиктела.
Didi, because
Yeah.
you're practically
Yes.
almost done, I will switch to another
Okay,
center just to
okay.
present their cases because we were all the time with
Yes,
you.
we will
Okay.
show final result, yes.
Yes. Okay. Can we switch
Thank
to
you,
CT?
thank you.
Okay.
Because as far as I know, they practically finished their case. Okay. Can you switch to CT video? This is CT, but this is video not from CT clinic. Okay.
I can guess you hear us.
Yes. Hello, Ivo.
Hello. Hello, everybody. In fact, we have a case. We progressed quite a lot inside the case. I have here my team. In fact, they did the main part of the job and I just entered. In fact, Kate, Rossi, our nurses, Docent Stoikova, Docent Stankov, Alexander, the X-ray technician. Okay. And in fact, Dr. Kadiska is probably ready to share with us and with you, of course, the case, what it's about, what is the planning and what we have done. The most important that the patient is doing very well, so we have all the time necessary to discuss and to do everything. Okay, Dr. Kadiska, it's your turn.
Hello, everyone. I'm here to present to you another case from Acibadem City Clinic. It's a pleasure for us to be here today. So, this is a patient, which is a man, 67 years old. He is presented to us with chest pain and some other pathologies which make him feel the pain also in his left hand. And these feelings he has also when he's in rest. So we have done some diagnostics before, and we can see that his left main artery is with occlusion. Also, all of the other LAD, RCA, and LCX are all pathology. All with pathologies. Here you can see a case which has really general atherosclerosis. He has another hospitalization in which we did PTA in right carotis interna. This was last month. He also had ischemic insult in 2012, which is hard for him to walk. He also has hyperthyrosis, and also he presented to us with some blood results, which you can see later in this presentation. Here is the ECG on arrival, which doesn't have a lot of changes. This is the echocardiogram on the arrival of the patient. We didn't see nothing to say. All of his the mitral valve and the aortic valve also work well. The ejection fraction is preserved, and here you can see the strain of the left ventricular, which shows some changes, which are in correlation with the angiographic result, which you can see later. Here are some of the images of his coronary arteries. You can see that they're tortuously changed. And as I mentioned, this is the blood results. He presented to us with very low hemoglobin, 77, in which we did hemotransfusion. of only one blood.
1 unit.
Yes, one blood unit, and his hemoglobin from this hemotransfusion, as you can see, is pretty well compensated. After we discussed the patient, we calculated all the scores, and as you can see, the Euro score is 4.12%, which is because of his extracardiac arteriopathy, which is intervenated in the past. I'm talking about the right carotid artery. The STS score, morbidity and mortality rate is extremely high. This is 15.8% because of his liver disease. And here you can see all of the medication we used for him, which is, of course, dual anti-aggregant therapy with beta blocker. In his case, because of the liver disease, we chose propranolol. We treated his arterial hypertensivities with amlodipine and telmisartan. He also has diabetes, which is on insulin, and the rest is for his HEPAR. This is the syntax score, and after our heart team discussed, we decided that the patient is ready for endovascular treatment. This is it, and now you can see more of the live case.
Okay. Thank you, Dr. Kadijska. Dobri, I will ask you, is there some non-Bulgarian speaking audience?
Yes.
Okay, good. We continue in English. So,
Dr. Gorgo is here. Dr. Shevket is here. Dr. Shevket.
Shevket, hello. Very nice to see you here. Welcome.
Yeah, nice to see you too, Ivo. It's very interesting to see you doing a coronary case here. Even your assistant said this is going to be endovascular, so she's confused as well, like me. So it's very interesting to see you. You are the king of the endovascular, I know. Well, let's see what are you going to do here. So I'm very excited to see you here.
Okay, thank you so much. In fact, Dr. Stankov did the case to this moment. In fact, but we are doing probably about...
Yeah, but Ivo, that's always the case. Dr. Stankov is doing the case and you get the credit.
Yeah, this is the life, you know. But he did the good part of the case.
Try not to mess it.
So, okay, let's jump on the job. So this was the situation in the beginning. You see really critical right coronary artery subtotal. Hopefully you agree that in this case we have to start with the right coronary because it's really critical and there is imminent closure of the right coronary. And because the LAD was pretty free of disease from the first angio, from the diagnostic angio, we decided, in fact, the plan for this case was to open the right coronary and to take a look at the osteostenosis of the circumflex artery. That is we are going to take a look now with the OCT, but it looks like it's really isolated osteo-CX. We know very well that such an animal like pure osteo disease of the LAD or the circumflex almost doesn't exist. So probably the plaque is protruding into the left main, but this is on a second stage. So what Dr. Stankov had done, this was in fact, let's go for the next please. Yeah, in fact, there was a predilation with 2.75.
Yes, non-compliant.
Non-compliant balloon. But please tell about the case, because you have done the case.
Yes. We started with a brachial approach, 7 French, because we going for the left side with 7 French extra backup catheter, and we have a very huge tortuosity of the arch of the aorta and сега ще моля да пусни първо преминават с водача. And yes, I try to cannulate with guiding catheter the right coronary artery, but I can't. For that, I starting from the distance to cannulate the ostium of the right coronary artery, and after that, with the balloon, I'm selective cannulate. After the predilatation with 2.0, 20 millimeter balloon, I do a second predilatation with non-compliant balloon to 2.75 millimeter, and after that we implant two stents, one stent of the distal subtotal stenosis, 3.0, 18 millimeters, and the second stent on the proximal stenosis, 3.5, 12 millimeter. And let's see the final result.
And also the stent boost in a while. And if you allow me, I will share our experience for the right coronary artery. Probably virtually in 100% we are using left arm Platz catheter for interventions. Because of radio or brachial approach is not suitable for Judkins utilization in right coronary because in fact the support is very poor. And Dr. Stankov have shown a small trick to go, because the ostium of the right coronary is very low. It's on the bottom of the right sinus. And he did exactly this trick. From distance, he has cannulated the coronary artery and have used the balloon, the first balloon, as an anchor in order to cannulate selectively and more predictably the ostium of the right coronary artery. And you saw probably the result. In fact, probably 6 or 7 projection is the result. More. 16, I mean, not 7. Yeah, this is the result, the angio result. And we have done the stent boost that our technical guys will show the stent boost. Yeah, this is in fact the stent boost of the distal. And is it possible to show this?
Ivo, sorry for interruption.
Yes.
At what stage you are at the moment?
Now we are on already inside the circumflex and the LAD, and we are prepared to make the OCT evaluation.
Okay,
Let's go.
because in Tokuda they're almost ready to place mitra clip.
The mitra clip.
Yes, they're in front of the placing the clip, and
Okay.
I suggest just we will switch to there. And then
Okay.
we will go back to you to see.
I agree. We are going to perform the OCT
yes,
now.
just make the OCT exam, and then we will go back to you, and we will see this circumflex artery. It's very interesting.
Excellent. Okay.
Може ли да включим Tokuda?
Because it's going in the oblique position. Yeah, so we will go plus, and it will go towards posterior wall, so compensate anterior. I will go a little bit more towards the. So, please give the Please.
Valery, can somebody introduce the case?
Explain.
No 3D. Хайде да се слушаме, моля ви се.
Okay.
Точно вкарваме нещата и където сме там, просто не дайте да променяте.
We are to medial. Yeah, don't worry. We will check because the pathway will look much better. Could you go
On the clip.
Yeah.
On the slide spot.
Can we see the angio? At least for the audience.
Yeah, but more plus. Yeah, definitely. This.
Echo, angio, something else than the slides.
So more plus. Yes, I did it. Okay, and compensate.
Great. Okay.
I will go up and more plus again. Again more plus. And it's fine. And it looks much better. Yeah. Yeah, so we are exactly in the middle. So I will release the tension. Somebody should tell about the lady. Who is telling?
Yeah.
Okay, who will?
We can. Представете случай или...
Просто с две думи ни кажете все пак за какво става въпрос, какво гледаме.
Ние включени ли сме?
Да, гледаме ви.
Не го знаеме това.
Гледаме ви от няколко минути.
Гледате, ма кажете, че...
Ми казахме.
Не ни чувате.
Казахме, ма не ни чувате явно.
Не. Доктор Лицова ще представи случая.
Окей. Чуваме ли се?
Yes, in English, please. Okay. I'm sorry, but we have to speak in English.
I'm present the case in English. It's about It's about 84-year-old man with known mitral regurgitation, high grade, NIHA class 3, 6-minute walk test, 175, and from the SCAC we have no arteries, coronary artery stenosis. About the case, irregular heartbeat, permanent atrial fibrillation, the therapy, apixaban, bisoprolol, furosemide, dapagliflozin, lipoendropil, almost all the therapy for heart failure. Laboratory tests, nothing so abnormal. And this is from images from the TTE. It looks like a high-grade mitral regurgitation with central jet. And this is on the next slide. Maybe it's, I can't. Okay, this is the TE that we made. It's TOE. It's high-grade mitral regurgitation with pseudoprolosing of the posterior mitral leaflet and with several jets. And the big jet is on the central part of the A2, P2.
For 10 seconds of stop breathing.
Yeah. We have a little bit flare gap, which is we have measured it 4 millimeters. This is the TE with 3D echo with the central jet again, the mitral regurgitation, and our heart team decision was for TIER with high STS score for mortality morbidity and for operative mortality. This is us. Do you have any questions? Or we can continue with this?
Let's continue with the case, please. I saw that you are close to implanting the clip.
No, we are just, it's nice to hear you, Julia.
No, thank you. Nice to hear you too, Valery.
We made the puncture. It was a little bit strange from what we usually use because we should be very precise on the distance of the puncture to the mitral annulus. Finally, we did the puncture. This is. Can you see the angio?
The angio, no. We can see the echo.
Okay. On the echo, можем ли да покажем предишните неща, пункцията?
Yes, now we can see the angio.
So this is a process of getting through the septum in upper pulmonary vein with the after that exchange for a stiff wire. And now you can see probably if you you can change to the angio, you can see the puncture. and it is very well seen, but to tell you frankly, it is quite difficult and different from what we usually do for, let's say, for mitral stenosis, I mean mitral valvoplasty. Anyway, we got the system up, and we are just adjusting the clip in front of the mitral valve. And if you go, сега на живо да се видиме, this is the position of the clip. Of course, the most important is the echo, and we are going back to the... Could you explain, please? And now we are going to...
A little bit posterior.
Okay, you can see the clip, and now we are going to go posteriorly. Of course, I forgot to mention our whole team. Dr. Januszka, Rafał from Abbott, Dr. Zeleva, Dr. Radoslavova, Dr. Litsova, our colleague anesthesiologist. And of course, it's a big team. We cannot see all of them, but now we are checking the...
Explain, please.
We're checking the clip. You can see that it is open. You can see it on the angio. And now we're going to check the grippers to see which grippers correspond to the position, anterior or posterior.
Yes.
This is the anterior, and then we can check the posterior in order to be able to grasp the mitral leaflets separately.
We will go a little bit anterior. Okay, right?
Let's record this, please.
We are diving, yeah? Because I can't...
One explanation maybe for the people in the auditorium is that MitraClip procedures are done mainly by echo guidance. The echo guidance is very important in this procedure.
So I'm going towards the 3D.
Let's have a 3D, please.
And decrease the gain. So we want to make proper orientation of the mitral clips, which is, I'm going counterclockwise.
This is what we are doing. Probably you can hear Dr. Januszka that we are trying to get the clip is inside, and we are trying to orientate it perpendicular to the leaflets and in the middle of the...
With the trackball a little bit towards left. Echo.
Yeah, we had it in the second.
Okay, perfect.
Second ago.
No, it's fine. Okay, so I will a little bit change the positioning. Okay, and what do you mean pullback? Yeah, okay. And let's go towards the anterior. Yeah, definitely. So, and now.
So you rotate the system
Because
clockwise or counterclockwise? Just a few suggestions about that?
No, we are going counterclockwise to keep it something like 12 to 6, the arm orientation. And I mean, this is not bad, but I will go a little bit towards the middle. It looks that we are in good position now. Okay. Is much better?
А друго си да погледнеш с ангиото.
I know. I know. Yes, please.
Let's go intercommissural view, please, right there.
So we will check it in the intercommercial, but I need to go a little bit towards the. Yes, yeah. So we are going a little bit with M to the middle of the valve. And it looks not bad. But we need to go posterior. And again, I mean, we still need the plus. I'm not sure what is going on. And let's go towards the anterior. Like that. Okay.
So you see that this really quite difficult to make because you have so many small movements of the mitral clip, and we have to make the right position just to get into the valve and to.
I will go to improve the straddling.
It's like observing Japanese type opening of CTO.
Yeah, it's too far, actually. Yeah. Now it's better. So.
By progressing in 2 millimeters by 20-30 minutes.
I will remove, I will do something else. Because
for the audience, this is actually maybe not very attractive, and the show here is not
I mean, there is no big show here.
Yes,
it's
exactly.
important to make the
stay calm.
Yes,
this is why.
This is why. Yeah.
And it now looks better.
You can imagine that there should be a synchronization between the echo team, between the two operators, just to. Because
Валери, ако искате само да видим в другите зали, в другите центрове какво са, нека да включим болница Чирков, професор Трендафилова да ни покаже крайния резултат от клапата. Имаме ли връзка с тях? Ако не, в City Clinic със сигурност те са в действие. Да включим City, моля. Здравей, Иво. Hello, Иво.
Здравейте. Значи, какво направихме? Направихме OCT. Absolutely, yeah. Shevket, in our experience, in fact, we are doing half and half coronary and peripheral cases, endovascular. But
yeah, that's the reason why you use the brachial artery for coronary. Half endovascular, half coronary.
The brachial artery is excellent artery to have also coronary access.
Yeah, but when you have experience like you won in your shoes, it's easy. But you know the brachial artery has still more complication rate than the femoral and the radial artery. It's about experience. But this is a congress, and from a teaching point of view, I am here as a panelist, and sorry, I have to say something here. So that's the reason why I'm talking about. So I think I don't think many coronary interventionalists are familiar with the brachial artery. So nowadays, you know, in Europe and everywhere, we are very fan of the radial artery. And we have more and more cardiologists. They are only doing radial artery. So maybe the radial artery is here occluded. What was the reason you used brachial artery? Just to make a point here.
In fact, I don't know.
Occlusion of the radial artery from the before procedure.
For the previous.
Then you can use the ulnar artery. There is no harm on that.
You're right.
We take 7 French sheet.
Also not a problem. We have sheetless Asahi. I have used it today with 6.5. It's a glide sheet. You can use it very easily, and you can also make a slender sheet there. And 7 French is not a big problem in radial and ulnar artery. Just making conversation, Ivo. Just to making it a little bit, heating up.
The main reason to use the brachial artery in all our cases that we are using the brachial artery is the extremely low complication rate that we have.
Yeah, so but it's for you, not for us guys, for the most majority of them. Yeah.
Everything is based on the local experience and local results, also like surgery. Okay, let's, we have shown probably very few pictures. Let's start from the beginning. You saw the right coronary artery, and we are going to proceed with showing the left. Go.
Next.
Go ahead. Okay, this is the left coronary artery with left main that is good enough. There is a middle segment plaque, about 20%.
Can you give us an insight about the wires you are using here? Which wires do you use here for Walker's wire?
We are using, I think, the run-through is in the LED and the first marginal branch. And we have a third one now, but I will show it the third one after that, the whisper. Go ahead. So during the case, you see a critical stenosis of the LAD, and only by teaching purposes, we have done also FFR and RFR, and in fact DPR. And the DPR resulted to be 0.68. So something that we knew in advance, that there is definitely a significant stenosis. Next, I'm running the non-interesting part. So this is the stent into the LAD, 30 by 80, 22, 30 by 22. And we did also the stem boost with excellent result. And after that, we switched to evaluation of the osteostenosis of the circ. And okay, we pre-dilated this stenosis with a non-compliant balloon. And now we are with the OCT catheter in the first marginal branch. You see, this picture is quite good to realize the real osteo problem of the circ. And now our friends are going to show the result of the circ. We did both OCT of the LAD and OCT of the circumflex artery. And we have a very important information collected.
Ivo, if you don't have,
yes.
If you don't place any stent in this marginal already, can I suggest some simplification of the procedure?
Absolutely.
Do FFR of this lesion to marginal branch.
Okay. Yeah. Okay.
I think
absolutely agree.
This could simplify a lot the whole procedure.
I never have heard you are a lazy guy, but you.
No,
you
just as a catch, you know.
Yeah,
it's
First, hello, Ivo, and then
yes.
you know that all cases, the simpler, the better.
Absolutely, I agree.
I agree with Dobry here.
Yeah. Okay. Totally agree. Excellent point. Excellent point.
Because this is very focal short lesion, because there is a long lesion in the circumflex, but it not seems that it covers too much, too great, so great area of myocardium. And
you're right.
if this,
we have discussed,
if this lesion is not significant towards this early marginal or intermediate branch, that will simplify the case very much. Otherwise, you go in double, triple kissing bifurcation. This is a trifurcation, and it could become quite complicated.
A disaster. Absolutely.
Yes.
Totally agree.
So if you can escape from such a scenario, yes.
Okay. We are already distally.
Yes.
We have to equalize. Yeah, I'm just outside the cut, so now is the moment to make equalize.
So, Ivo, I have another suggestion. Have you checked the ACT, because you have already done the the RCA, and this is going to be a long procedure. And do you have any practice regarding longer procedures looking at the ACD?
In fact, we don't have such a protocol, but we can check it. Yeah, good idea. We are going to do that.
In our lab, we just give at any 60 minutes 1,000 units of heparin.
This is our practice as well.
A regular base. We give 100 units of heparin per kilogram at the start of PCI, and then at every 60 minutes we
this is our protocol as well.
1,000 units additionally. Just.
Let me see.
Of course, ACT
Something
is best.
Here. Може би конекторите или тук? Това стерилно ли? Я изводи го и го пропустим пак. Окей, go. Strange. We have some problem with the measurements.
Did you flash the system with water?
Yeah, we have flashed the system, but unfortunately there is not any reading.
Everything is okay. Technical problem.
The reading appeared. Okay.
Can we see? Yes, we see.
Yes, yes. I will introduce now the FFR catheter inside the marginal or intermediate.
Because I saw how easy the Navus catheter crossed the lesion, I'm a little bit. Sorry? Did you give nitroglycerin? This is because.
Oh yes, yes, several times during the intervention.
Okay.
We are going to equalize now, and yeah, we are ready for equalize. Okay, on the tip of the catheter we did equalize. It's a 1.
Excellent. So
the reading.
Go
is
ahead.
1. I'm crossing the bifurcation, and we are already distal.
Okay, so now you can measure DPR.
Yeah, we are flushing.
Just to
yeah. Go, DPR.
Just to remind that practically the last results from Swedish Heart, it's 81.
81.
The last results from Swedish Heart registry demonstrated clearly that FFR is much superior than non-hyperemic than
we are
IFR.
Now FFR now.
So
adenosine.
This is why, and regarding the mortality, it's a very, very hard endpoint.
We are going to put now hyperemic.
This is why you should do always DPR or any other IFR are very good for orientation, but
absolutely,
FFR is the guiding.
It's like a pressure gradient, in fact, the DPR and the
yes,
IFR.
during hyperemia. Now you can measure it. Just it was around 0.80 something. Okay.
Again.
79. Okay.
77.
You started intravenous infusion with adenosine, yes?
No, intercoronary.
Infusion.
Infusion.
Okay.
Yeah, it's 0.77.
0.77. This is in very good gray zone.
Yeah.
Before the.
It's a very good gray zone.
2018 guidelines for myocardial revascularization, just to cover the gray zone, and this is why.
I will, if you agree, we are going to show you the OCT results, and we will discuss after that the strategy, strictly osteal stent of the circ or left main to circ. And okay, let's play the readings from the play. Yeah, exactly. So this is, in fact, the evaluation of the marginal toward the left main. Go next. We have evaluated, in fact, this is the, we have measured, дай ги всичките регистрации да видим кое е. Давай LED. Okay, now we are going to show you the LED OCT. Also, you probably remember that there is a stent, ostial stent of the LED performed years ago, several years ago in another institution, and the behavior of this stent is quite good. So it's a quite very good endothelialization, but no any significant restenosis. These are the struts of the stent, you see. And now we are approaching the bifurcation of the left main. Okay, stop. Go back, step by step. Go back. Okay, stop. Okay. So this is the bifurcation. In fact, there is a very small strut, white, exactly this. That this is obviously the strut of the LED, ostially positioned LED, that is slightly protruding within the ostium of the circ. So, but it's not obstructing.
This is a very good example why I'm doing in 100% when I stent the left main across the circumflex, why I'm doing in 100% kissing, because this stent strut will never disappear from there, and if it endothelialized, you're doing now planet PCI, but imagine what will be if this is a acute MI case.
Yeah. In fact, it will be without doing the kissing, will be a mini crash. Without kissing, that would be a mistake, in fact. And okay, so what is your proposal? To stent from the left main to circ, or that is in fact our proposal to go stent from the left main to circ, and after that to make the kissing.
If you want to make your life difficult in next 1.5 hours, you can stent from left main to intermediate.
Yes.
Because you should also, there will be no way, in my view, to protect also, you have to think about also the proper circumflex. It is not huge vessel, but it could not be disregarded. So it depends. The FFR is 0.77 is not so...
Gray zone. Yeah.
Yes, it is according to the guidelines, it is below 0.80.
Yeah.
And if you want to justify PCI, you already justified.
Yeah. But in fact, okay, let's vote. I in fact will accept.
Okay, let's ask the audience and maybe first the panel.
In fact, I think that this is the ideal candidate which is not suitable for a left main PCI. As far as I remember, this is a patient with anemia with hemotransfusion. The patient is double platelet therapy with NATA-spin with improved effect on aggregation.
Very good point. Excellent point.
So in this gray zone, for me, it is not gray zone.
Okay.
I think that Dr. Matei finalized the clinical point of clinically wise point of view.
It's excellent. Excellent point. Thank you for that. Definitely. And Sashko, давай другото.
Ivo, I want to just to switch to Chirkov Clinic just to present the final result of their case. Можем ли да Само да видим. Да, и след това ще се върнем при професор Петров.
Excellent. Да.
Те са на втория кейс.
Окей, чуваме ли се, колеги?
Да, Диде, можеш ли да ни покажеш резултата от преди първия кейс и тогава да...
Okay. We'll show the final result of the first case. Краси, дай...
Orthography. Final orthography.
Final orthography. It's okay? Do you?
Yes, it's okay. We can see perfectly.
Yeah. Okay.
The valve, there's practically no regurg.
There is no regurg. The gradient is 8. I think that can you show the
Hemodynamic.
The gradient?
Yes, we can see that. Thank you. Very good. Very good.
We successfully closed the femoral artery with Manta 18 because the sheet is 18. Can you show the peripheral angiography?
Excellent. Bravo.
It's okay.
And we are very happy to have left coronary artery.
Yes.
Also.
As a comment, we have quite good experience, I would say, about Allegra valve system. And this is the valve system which shows the very low gradients, especially in small animals as a women and in valve procedure. So this is our first case. So we can show our second case. Dr. Bojana Barzashka will present you.
Hello, my name is Bojana Barzashka and I'm going to present you the next clinical case. It's a 76-year-old female coming to our hospital with complaints of tiredness, dizziness, and tingling of the left hand, which is provoked by physical exam. She has arterial hypertension with arterial pressure 150/80 on the right hand and 110/70 on the left hand. Her comorbidities, except for the arterial hypertension, she has dyslipidemia, impaired glucose tolerance, she has ovarian cyst operated in the past, chronic gastritis, hypothyroidism, and chronic kidney disease 3A. Risk factors: her age, arterial hypertension, dyslipidemia, and impaired glucose tolerance. Her treatment is double antiaggregation, small dosage of diuretic, optimal antihypertensive therapy, and anti-lipomimetic therapy. Her ECG shows no significant changes. Echocardiography, we have preserved ejection fraction of the left ventricle with normal volumes and sizes. No severe hypertrophy. We have particularly, the valves are intact with no pericardial and pleural infusions. From the lab tests, we see the high glucose and the EGFR, which is 52.8, which makes us 3A, chronic kidney disease stage. We made a Doppler sonography, and what we see is a turbulent flow from the carotid artery and high velocity, pulse wave velocities. We made a coronary angiography, and we observed a non-significant coronary pathology with preserved ejection fraction of the left ventricle with no mitral regurgitation particularly. We did peripheral angiography. We observed left internal carotid stenosis of 80%, and the right internal carotid stenosis of 90%, and 90% of proximal stenosis of arteria subclavia sinistra. And our final diagnosis, we have a severe stenosis of arteria subclavia sinistra, and we have bilateral asymptomatic cardiac stenosis, over 70%. What we do next, the guidelines tell us that when we have a...
Okay, can we leave the discussion about between the panel and operators, okay? So, Diana, what is your plan now?
Our plan is to start with subclavian artery, and then to proceed with carotid artery.
Okay, with the direct stenting, or because yes, there is a vertebral probably.
Yes, but
something like
There is a vertebral. Right vertebral is higher, is bigger.
Yes.
And we decide to start with left subclavian artery in order to comfortably working with left carotid artery. If you see from presentation, there is no posterior communicant arteries in this lady on circulus of Villisi. Now we proceed with this subclavian.
And we discussed to predilate because there is a lot of cauchy and the stenosis is severe according to me.
This is 7 or 8 French guide?
8 French Judkins right guiding catheter.
So you will predilate with what size of the balloon?
We have 520.
520, okay.
Yeah.
Maybe we will leave you just to do predilatation and we will switch to Tukuda because they are already placed their mitra. Can we switch to Tukuda Hospital? Hello, Valerie again. Eva?
I'm there.
Здравейте! Чувате ли ни?
Здравейте! Това, което...
Explain, please.
What we are doing now, we are just trying to grasp and to position the clip at the right position because you can see the posterior and the anterior leaflets are almost on the right place. So
wait, yeah, it's perfect. And don't move with the pen.
And I said we should be coordinated with the echo team.
So anterior is
now we're
that one.
Pushing the gripper.
We can't see.
So we left you probably almost at the same stage.
Yes, but it was necessary to when we are not we catch the anterior leaflet, but it was not possible. It was not possible to catch the posterior, and finally
and she's got the anterior flex of her.
And finally, when you grasp the leaflet, you should have enough place and enough length from it into the mitral clip. That's why we have to reposition the whole system, and now we went inside again. Now we are having some issues with the image from the echo.
Okay, now it's better. And stay just retroflexion, please.
So now you redirect the mitral clip.
And we are to medial.
We cannot hear you well.
Okay, Do you agree just to go to city and then we will go back if you are in a better position? Just okay. Can we switch to city just to see what Professor Petrov done? Hello, Ivo, again.
Do you hear me?
Yes.
Okay, excellent. So, in fact, we have listening to you very carefully, and we accept the reasons, we accept the motives that you mentioned, and what we have done. We did non-compliant balloon second inflation, 3.0 by 12.
Where?
And,
in which vessel?
On the circ,
Uh-huh.
And in fact, to be, let's say, to improve the remote result, we touch the ostium of the circ with drug-eluting balloon, drug-coated balloon, and okay, and this is the final result.
Okay, it looks very good. And
this is the final result.
And probably
Absolutely.
you should not do anything more.
Yeah, I hope so, because the flow is symmetry everywhere. There is no visual dissection, and I'm with the OCT catheter almost there. And
as Bernardo Cortese said, the imaging check is not the best for those cases, maybe.
Yeah, most probably we are going to see a dissection there, but we are going to be, let's say, conservative, not very aggressive. Let me see.
There is an ongoing study at the moment with the drug-coated balloons where the DCB is performed with FFR guidance.
Yeah.
Even one Chinese study was already published, and the results are very good, by the way. So, and the guidance was by functional assessment, not by angiographic, because assessment, because angiographic result, in your case, by the way, it's very good. For me, it's absolutely satisfactory.
Yeah.
And even it is surprisingly good, to be honest, at least for
Absolutely agree. In fact, it's a complex case, critical, right?
Yes.
Very significant LED.
Absolutely.
And this circ that I think we did the best choice together with your support.
Probably from Dr. Mateev was the best support.
Absolutely.
The clinical wisdom is for the first on the first place.
Absolutely. Totally agree.
So you try now to reposition the wires and to make an OCT in the intermediate branch.
Because there was a very big tortuosity on the level of the subclavian artery, we don't have a very good support, and there is some friction. And,
but if you try just to remove the wire, give nitro, check the result, and finish the case, will be.
Well, this is my idea. Yeah, this is my idea to make.
You know that I'm very aggressive, but this case for the life after right coronary, after LED, and everything else.
Okay, I have the cutter very good on the ostium, so the...
Julia, what do you think?
I think that's enough for the patient. I don't think that you should go on. The more you go on, I think you may get into problems entering again the vessel, and I don't think you need that. In a clinical point of view, I agree with Dr. Mateev. In a clinical point of view, that's quite enough, and maybe we can see the end. I think it's a good result. It's a good result. And you saved the circ, which is important. Intermediate and circ vessel. Otherwise, it would have ended in problems, I think.
In fact, yeah, you agree. I agree totally with Julia because it's a patient with a very severe ischemia. And now, in fact, we have improved the supply in all the 3 territories, and we don't. This patient doesn't need anymore with this result. And yeah, we are finished. Thank you very much for your
Congratulations, you.
attention.
Good job.
Good
Thank
job.
you. Thank you. Bye. Stay safe. See you. See you later.
Okay, can we switch back to Chirkov Clinic?
А Димитрова да дойде да ми донесе вода
Диде,
260
онлайн
или 300.
Диана.
Чакай да видя дали ще се
Не,
покаже.
не,
Чакай,
много гледа.
Диде,
Я да видя колко. Докъде стига?
Guys, you're online.
Момент, така ще опитам да влеза.
you're online.
Чакай,
Do
изпълни
you
го
hear
да ми
us?
се покаже.
Пейо, do you hear us?
Не, той не минава. През Y не минава.
Няма да ти мине с този водач.
Чувате ли ни, колеги? Чувате ли ни?
Освободи игрока.
Освободил съм го, но не минава през Y. Бутни го
Okay,
това водач.
so maybe we can comment from here.
Or shall we go to the...
Okay, let's switch to Tokuda.
Дайте румото.
Не ни чуват, няма.
That one, is it intercommissional? Because we can see only one papillary muscle. That is better.
Hello, Valerie.
Okay.
Again, you're online.
In the same position.
So we are just fighting, and this procedure is actually perfect because we can try to grasp it and find the proper place several times. Explain, please. So you know that you can see that we've got quite well perpendicularity in this place. And I will try to close a little bit. Yep. So, and I'm going towards the left ventricle. So just we are reaching the place where we will be below the valve. So I'm opening again for the grasping position. Okay. So now looks very well. So it's okay. It's okay. So we can't grasp correctly the posterior leaflet. So the posterior leaflet is rolling over the arm. So this is why I'm trying to find out better position and better grasping angle. What is? Yeah, but yeah. Now, so we've got posterior leaflet fully in. So posterior is that one. So we've got the posterior. We will little bit close the system, and I will try to go for anterior. So, and now we need to go below the anterior, which could be quite difficult. And I can't, yeah. We've got the short part anterior inside. So what we will do, I will grasp it, and I will change the grasping amount of both leaflets step by step. So I will just close it a little bit. Perfect view, thanks a lot. And now I will open the posterior. Just release the tension, so we don't have the grip on posterior. Yeah, but the grasping looks better. So I will a little bit open it. Again, I'm going for posterior. I will recapture the anterior because it seems to be that we don't have enough anterior. So I will a little bit open it again, and we will try to go for anterior. Yeah. So I will push whole system, which we lost the position, but it's not fully true, because we've got the posterior and we've got enough anterior. If you can see, there is lying the anterior on the arm. So I'm going a little bit up. I will go with the gripper, and we will try to close the clip more. Yeah, sorry. I need to open it again. So we a little bit lost the posterior. So I will go up. And we are closing, and you can see that that is behind somewhere else. So we will check. More towards the. Please go a little bit more to the lateral. And we will see the base. Lateral, no? You are going to medial. This is medial. Please go lateral.
Okay, in Chirkov they are ready.
Yes, so you can see that we've got clip secure, and tension on the anterior as well. The posterior looks also not bad, but we will work on it again. And this is what I told, that sometimes the procedure definitely takes a lot of time, because we need to get proper position, proper amount of leaflet, and we will see what happened. Yep.
Okay.
So, could we check the color?
You now, what you plan to do now? Just echo?
I will show you the color.
Mm-hmm.
And do you see any regurg?
Great.
It will be in the middle where we didn't get the clip, but we severely reduced the regurg, even with one clip, even with not the best grasping, and you can see that the anatomy and flow through the mitral valve is absolutely different. Yep.
The result looks very good.
Absolutely.
So,
but we will work on it, because this is not the best grasping, and we need to improve it.
Okay. So we will leave you to work quietly, and we will come back in a few minutes. Just let's go to Chirkov Clinic.
Okay.
Bro.
Hello. We are already finished with the subclavian artery.
You're very fast.
Yeah, we proceed to left carotid.
Can you show us the steps of?
Okay, I will show you.
Balloon predilation.
Predilation.
That was 5-0 balloon, yes?
Yes, this is 5-0 balloon. It was a huge stenosis. You see, after that we put a stent.
What type of stent is that?
Omnilink, peripheral stent.
29.
8 over 29. This is
Positioning.
Okay.
Positioning of the stent.
Yeah.
Excellent.
And this is the implantation.
Opening.
very tight stenosis.
Yeah, very tight stenosis, little protrusion in the aorta. And
we lost a wire, so we decided to go to the carotid artery, and then with 5 French diagnostic Judkins catheter to check coaxiality of subclavian artery.
okay.
And now, the left carotid.
Yes.
Left carotid, we will see now.
We'll go first the 8 to the Judkins catheter, to positioning the wire, then to change it with the cart wire, and then to go to the...
I'm sorry, I probably missed something, but I see that there is a stent in the right coronary, the right carotid.
Yes.
This is the 2 months ago, the patient
okay,
from
because
the
we missed during the presentation this point.
Yes,
okay.
We stopped
This
them.
is the patient with 2
stopped
bilateral carotid stenosis and severe stenosis of left subclavian artery.
Okay.
We can show you a couple slides from a presentation.
No,
to see.
we saw it and we see the stent. Just
Okay.
Yeah.
and the geometry of the stent is perfect. Just
yes.
Let's go to diagnostic catheter. The right.
It's not an easy anatomy, though.
Yes, very elongated artery in the first part of the.
It's not easy. Carotid artery, and I remember the right was the same.
That's
with couple to.
Thank you.
Smeníme se. 5 French. We will take 5 French catheter, Judkins right.
So cannulate. Okay.
It was too big, 8 French for this carotid. We performed CT angio in order to check the result from previous stenting, and the stent in the right carotid artery is very well. Okay.
Иди в пас.
Да, ще ми по-удобно да я каналирам.
Окей, да. Давай водача напред да имаш хвали.
Окей.
Добре, чудесно.
Окей, давай, още. Долу имаш крив.
Момент, само че ще не пипам катета.
Окей, супер. Go. Stiff wire, please.
Бърни главата на дясно и няма да. Окей. Ме клича.
Вече може да.
Дай гличка ми дай. Тук се вижда. Момент. Секунда.
Can you tell us in the meantime what kind of a protection device you are going to use and what would be the length and size of the stent?
Yes, as you see of the presentation, the conclusion that in these patients, proximal occlusion is not recommended due to circulation of Viliziev circle. So we will use filter wire, filter embolization device. We don't have other. About the size of the stent, we choose 6, 8, 40 as a length. 40.
40, yes, thank you.
And distal protection is spider, 5 millimeter spider. Ce să mi-l It's going to be like some sketches.
One question, please. Which kind of wire, diagnostic wire, will you use? Because you need support, there is tortuosity.
Now I'm with stiff wire.
Hydrophilic, you mean, maybe?
No, the first one wire was hydrophilic. Now we will change the introducer onto stiff wire, which is extra stiff wire.
Okay.
Yeah, what is the brand of the wire? Is it an Amplas stiff or is it a, what kind of brand is this? Amplas stiff, okay. So I agree with my friend here. I think you should go at least into the external carotid artery. This stiff wire, this stiff wire may not carry your diagnostic catheter, and you will fall easily into the aorta. And if you even manage,
I will try. Okay.
Yeah. But even if you even manage to go with the stiff wire, and you will put it, you don't know where to go because you don't have any contrast flashing there. So, but you don't. If you go into the internal carotid artery.
I'm in external.
Yeah.
I'm in external.
That's good. Yeah. And now you have the leverage now. Yeah.
Yes.
Yeah.
And you will use again a Judkins, right? 8 French or shitless catheter?
Shitless catheter?
Yeah, shitless would be preferred here.
Neuron Max.
Neuron Max.
Okay.
Good choice. It's very flexible and safe.
Ще излезеш ли да излет?
Ма не бе, то по него върви.
Ще минем ли?
Да, абсолютно.
Окей, супер.
Мисля,
че това ще е.
После обадим това.
Да, супер.
Няма смисъл.
Ще трябва да намалим увеличението.
Да, чакай, тъй бавно. Дръж водач.
Да, не е достатъчно изпълнат, така че.
Чакай, че.
Бавно ще напредвам, за да мога да сдържа. Окей, чакай, че много...
Държа.
Малко го изтегли. Окей.
Чакай малко.
One question from the audience. Did you use roadmap to help you to see the external?
No. We don't use roadmap. Sometimes, but in this case, I didn't.
So usually I use a sim or headhunter or vertebral, just 4 French from the very soft one. There is this Merit catheter, and you can also make a Y connector at the hub, and then you can see with extra support wire like Sion Blue extra support or Choice PT extra support, you can easily wire whatever you want into the external carotid artery. You place your vertebral artery into the external carotid artery, then you are safe. But here you did a good job here. So I always prefer the long but safest way.
Стигли се. Добре сме. Изтегли се с дилататора. Okay. Good.
Okay, as I see that
we passed the first tortuosity.
Exactly.
Successfully.
Okay, so we will leave you for a couple of minutes and we will switch to Tokuda because they finally catch the valve in proper way.
Okay. The catch in the right.
Sorry,
Може ли Tokuda да ни пуснете?
We recaptured once more the mitral valve. We tried to put inside more anterior leaflet. You are seeing the posterior leaflet, which is also very well attached, so it's just straightened. You can see just beside the clip that the posterior leaflet is very long. So could we check the core again?
Valery, you are online?
Yes. We are just discussing that If I resume, the process was first we went into a position and we tried to grasp both leaflets, but it was not possible because the posterior leaflet was rolling out of the mitral clip. After that, Dr. Januszka went and he grasped the front leaflet, and using it as a support, we separately, he went a little bit higher and grasped the posterior leaflet.
Yeah.
During this process, we have a, let's say, result that was acceptable, but when we measure, it seems out that there is not enough grasping part of, not enough part of the leaflets were grasped, which is, of course, not acceptable because the mitral clip can get detached from one of them. That's why we reopened first the front, the anterior leaflet, and after that a little bit the posterior. And I think now we have in a good position, according to probably all of us. What we have to do is to measure again and to be sure that we have enough length of the leaflets grasped into the mitral clip. And of course, to evaluate the degree of the regurgitation. Something, please, Januszka, correct me if I'm not. The real picture of the mitral regurgitation will be seen when we have released the mitral clip, because the whole system at the moment is attached to the mitral clip, and there is a tension that is changing the movement and the real morphology, let's say, of the mitral clip and the real movement of the clip after the detachment. So that is what we are going to do in a few minutes. Any comments?
No, I mean, the mitral clip it looks like it's good attached, but we need to measure the length of the anterior and posterior leaflet just beside the clip. Now we are just close to commissure, so, and in different place, so we can judge according that position.
We have to find the position of the estimation before a mitral clip, and what we are measuring, what is left from the clip, and finally we are calculating what part of the clip is, what part of the leaflets is inside the clip and is grasped. This is very important because what we have on the anterior leaf is that it was grasped, but there was a booming of the leaflet, and finally when we measure this curve of the leaflet, it turns out that we are lacking some of the length which was necessary to be grasped.
By the way, what is the mitral regurgitation degree at the moment? Do you check it by echo? I mean,
now
with the Doppler?
we are going to check this, but anyway, what we are discussing here is probably this optimal positioning of this clip, and if necessary, probably it would be a better option to go for a second clip if the mitral regurgitation is not acceptably high, because I don't think we can have a better orientation and clipping of these leaflets.
It's not true. So from my side, what is very interesting is also that we've got very immobilized the leaflets in base of the mitral clip. So, but we need to check it once more, because this is not really very, because it's too far. You will see if we will have to. So, and the next question is only if we can release now, because we reduced the regurg from grade 4 to grade 2, which is not bad, but still, here is, we should, why you are changing for 3D if you didn't check the length of the anterior? So when is the anterior absolutely stop? Yeah, and we can measure the anterior from, please don't, now, please check the, yes, okay, it's 19 and this still is inside at least 1 more millimeter. And we can, okay, and we will check also the posterior leaflet.
What was the initial length of the anterior leaflet?
The anterior leaflet was little bit something like 25, but we will check it once more. So we've got 6 millimeter, which is not fully acceptable. It's on the border because we would like to have 8 millimeters and more, but the clip itself has got 10 millimeters. So we will check it several times because this is very important. The other thing is that we probably stop and now go back, stop, 1 ahead, okay, this is 2, 1 back, okay, and now measure please the posterior. No, it is not the posterior. You are measuring also the clip. So we need to measure only the posterior part, which is outside of the clip. Okay. Yes. So we've got 13 and it was more than 20.
More than 20.
So we've got definitely enough posterior and we will again check the anterior. But yeah.
So for posterior, you have grasped 7 millimeters.
Twice measured. So we will check the length of the anterior. If it's enough, we will release it. So anyway, we know that we've got 6 millimeter of anterior in. We've got very nice immobilized anterior. So we will try to go a little bit more medial from this position. Explain, medially, is medially, more medially. Yeah, it seems to be, it's too much medial. It's too much medial from the clip. No. Okay. Yes. Yes. And 1 more. Yes. And towards, yes, more. Towards the wall. It's a little bit more. So we've got around 28. So, and we get 19 over the clip. So we've got most likely 7, 8. If we are very lucky, so 9, but this is not exact. So this is acceptable grasping. We will release it, and we will go to recheck the regurgitation, or we will finish the case. Yes, and or we will continue with the second clip. So now you are checking the regurgitation. Yes. No, we are checking gradient.
The gradient, because this is very important. If the gradient goes up to
but the gradient is low.
What is the left atrial pressure now?
The mean pressure is 12. We can't tell you exact V wave because it's flat, because we've got mitral clip in the guiding catheter and the mean gradient. So we've got still possibility to add 1 more clip. So, but we will release the clip now. Yeah? Okay?
Yeah. So the plan is to we release this clip, and then to place
Then
another one.
try the mitral regurgitation, because I will repeat it probably that when the clip is on the system, he is interfering on the movement of the leaflets, and we will have the clear picture when the clip is fully released.
Definitely. Yeah. Okay. So we are releasing. So we are in neutral position. We are trying to reopen it. It's not opening. So we are fully closing the clip. So it's fully closed. Open. We are
Can you
opening.
focus on this part
The
here?
cap?
I mean, камерата, дали удобно тук да се фокусира?
Okay. Yeah, I'm just done. So,
can you see what we are doing?
so this is the lock line which is securing the clip skioscopy, and we are taking out the line. Line is open. So we are going to test the skioscopy. Neutral is not opening. Neutral.
You can see that it is quite a complex procedure, just releasing the clip. Several steps should be done just to be sure that the clip is...
Yeah. Hey, no, wait. I will, hold it, and I will just, so 1, 2, 3,
This should
4,
be
5,
rotated
6, 7, 8. We are unscrewing grippers up slowly. And
So-
we release the clip. And
The clip is released. Can you see that on the angel?
Yes, okay. We saw
this-
the mechanism and we were following the procedure of releasing
And
the mechanism.
if you,
We will switch for a few minutes to Chirkov Clinic and then...
we will show you the
If you want to see the regurgitation.
Okay.
So most likely we will finish at this level. Yeah? So these are traces, one. Okay, if you will agree, we will just tell you goodbye.
Okay, so let's see the stent placement.
Yeah, we are ready for.
What type of stent is that?
Exact. We
What-
start off.
Exact 6 over tapered stent, 6 over
And
8.
And the protection device is what? The protection device?
Protection device is spider.
Okay.
Now I will show you. This is the
Positioning of the
positioning
center
of-
of map.
of the spider. You can see in the straight segment of the internal carotid artery. And the next is stent placement, as you see already. And now we will post-dilate.
Go out with the stencil.
Okay. Okay. In this time we put some atropine, 1 milligram. Okay.
A little bit more.
Внимай, системата се бута на... Okay.
It's okay.
Готов.
So
We will post-dilate with balloon 5/20. That will be patent advisable.
Okay, Tukuda wants to be connected back.
Okay.
Okay. Can we switch
will
back?
show you a final result.
Yes, yes, you post-dilate. Okay, Valery, you are online again.
What we've discussed here, we just relieved the clip system, and we are discussing, and now we are checking the pulmonary backflow just to see what is the degree of the regurgitation, and we are discussing whether there will be a need for a second clip.
What is the regurgitation and the left atrial pressure?
Wait, please, because we are zeroing the system. So we will end within 5 to 10 minutes. Yeah. Thanks a lot. Okay. So, and I will show you the pressure. If you see the pressure, do you see the pressure?
No.
So is 15/0, and mean pressure is 7.
Can we see the left atrial pressure curve?
Could you just concentrate on the...
Maybe if you increase the pressure.
We will turn the monitor. Yeah, wait.
And the pressure range.
Yeah, the pressure range is now 50. So, and you can see we've got very low pressure in the left atrium. Yeah.
Another thing that is probably that you can see a spontaneous contrast into the left atrium. That means that the regurgitation is not that big.
It needs to have a little bit higher pressure. So, if it's possible
Okay,
to go from 130.
Yes,
it will
now
be fine.
it's
Yeah?
much better.
Thanks a lot.
What about zeroing again of the system and to remeasure the left atrial pressure?
The previous was, if I remember, 15, yeah. 12 was the mean, so we remove something like 1/3, and you should know that we add something like 1.5 liter of the fluids in his body because of the flushing.
Okay, it looks perfect, I think.
Yeah?
From the pressure point of view.
And this is from the echo point of view.
Do you see the echo?
Yes.
So, I mean, from the echo view, looks not bad. Yeah?
Absolutely. There is only trace regurgitation at the moment.
Yeah. So, from our side, I will tell you, we are finishing. We will just make the suture in the grave.
Let's not forget, this is 84 years old person, and I think what we have achieved probably will increase very much the quality of his life, and that's what we are aiming finally. Because the regurgitation was seen mainly with transesophageal echo, and now you can see that it is quite acceptable. It is really far away from what we had.
Yes,
Valery, I think the result is very good and satisfactory, absolutely.
Yes, what we aim usually in the edge-to-edge repair is to go below moderate, and to be sure that we are below moderate, because it was shown that if we achieve this result, it has an impact on the quality of life and on the prognosis.
Absolutely.
So we should not be, we should be really more moderate in our expectations, because otherwise everything additionally that could be done can in fact only have the and accumulate the risk of a procedure. So that is not really needed. So we are going to proceed with the closure of
Okay,
the vein.
congratulations for this case.
Thanks
job. Very good.
our guests, because it was really a tough case, and I would say that usually what we have is much more smooth, but it was, the anatomy was really
Yes.
challenging.
We appreciate that. Can we switch
Thanks to
back
you,
to
and see you later.
Cherkov Clinic? Thank you, Valerie. Thank you.
Agora aguenta.
Diana?
Okay.
We are finished.
We are ready.
This is the final projection. You can see please give the previous.
It was-
This is the result after pulse dilation with 520 balloon in the proximal and the
Middle part.
middle part, yes,
Yeah.
not distal part of the stent, and this is the final result.
Congratulations.
This intracerebral.
Great job.
Healing.
So thank you so much for perfect
Thank you.
demonstration.
Thank you. Thank you for partner.
So we saw 4 excellent cases, and now it's time for coffee.